Welcome to Lesson 2, Urinary Incontinence. So, what is urinary incontinence? It can be defined as an involuntary loss of urine that is objectively demonstrable and leads to a social or hygienic problem. The system of urinary incontinence comprises of lower urinary tract, nervous system, pelvic floor, and urine productions of mechanism. These are the morphological and functional changes that happen that include bladder overability and urgency, impaired bladder contractility, increased residual urine, decreased functional bladder capacity, prostatic hypertrophy, estrogen deficiency, and age-related. The approach can be divided into two. The first one is acute or transient incontinence, and the number 2 is chronic or established incontinence. In acute or transient incontinence, the older person may suffer cases of short-course incontinence lasting less than 4 weeks, including those situations in which loss of continence is considered to be functional without any associated structural disorder. The causes could be due to DRIP, D. delirium, dementia or diabetes, R. restricted mobility retention, I. infection inflammation, infection of stool, P. pharmaceutical agent or psychological causes. In chronic or established incontinence, when older person has longer than 4 weeks, commonly associated with structural disorder either in the urinary tract or outside of it, such as in nervous system, and transient incontinence may eventually be established or chronic in some cases. There are 5 types of incontinence, namely urge incontinence, stress incontinence, overflow, mixed, and functional incontinence. In urge incontinence, the characteristics that include are present as urgency, frequency, and nocturia, associated with a strong urge to void, caused by an overactive distressor muscle, causing excessive involuntary bladder contraction, and associated with various neurological conditions include stroke, spinal cord lesion, dementia, and Parkinson's disease. In stress incontinence, participants will experience action that increase intra-abdominal pressure such as coughing, sneezing, bending, lifting, or laughing, that caused by pelvic muscular weaknesses causing ureteral hypermobility, multiparity, hypoestrogenism, obesity, and pelvic surgical procedure like prostatic resection. Overflow incontinence, it occurs when the bladder muscle is overdistended, may present with a stress or urge symptom. The cause is an underactive bladder muscle or a bladder outlet or ureteral obstruction that leads to an overdistension and overflow. There are 2 different mechanisms that include bladder outlet obstruction and bladder contractile impairment. While for functional incontinence, it occurs when a physical or psychological impairment impedes continence status despite a competent urinary system. While for mixed type of incontinence, it including features of more than one aforementioned type. In terms of assessment of urinary incontinence, history taking should be include the onset, frequency, volume, timing, associated factors, or events. In terms of physical assessment, that should be include cognitive and functional assessment along with potential comorbid conditions associated with UI. Rectal examination is used to assess for masses, tone, and prostate nodules or firmness in a man, and the neurological evaluation should include evaluation of sacral cord integrity with perineal sensation. Vaginal mucosa should be evaluated for severe atrophy, and the pelvic examination should include evaluation for pelvic organ prolapse with straining. Urine analysis is done to look for hematuria and glyceria in diabetic patients. Also, pyruvia and or bacteriuria likely represent asymptomatic bacteriuria in women without dysuria, fever, or other sign of UTIs. Ultrasound or catheterization is used to look for post-void retention, especially in frail elderly. A clinical stress test by making a relaxed patient give a single vigorous cough may be helpful in documenting in patients with stress UI. Also, cystoscopy and urodynamic studies should be. In terms of treatment, numerous studies have believed that lifestyle and behavioral modification that are beneficial, including avoiding extreme or free intake, especially in the evening for nocturia patients, minimizing caffeinated beverage and alcohol, weight loss, and smoking cessation. And there are two main behavioral therapies that include bladder training and pelvic muscle exercises, and both of which are effective for urge, mix, and stress UI and are often used in combination. And pharmacologic treatment is largely limited to antimucosal agent for urge UI, overactive bladder, and mixed UI. Pessaries may benefit women who stress or urge UI, and duloxetine is used for moderate to severe stress UI, especially in women. Desmopressin is avoided in elderly UI due to its propensity and precipitated hyponatremia, and catheterization may be required in the case of chronic urinary intention or bladder impact contractility. Minimally invasive therapies available for those with urge UI refractory to antimuscarinic, including botulinum toxin injection into the bladder wall and sacral neuromodulation. Also, surgery may be beneficial in refractory cases, especially in the woman with stress incontinence. Okay everyone, I believe this is the end of our presentation. Thank you, and please don't forget to scan this QR code for taking your quiz and practical session. Thank you everyone. Bye.